the greatest medical minds
they are there still.
Are there, you know. And then the other thing is also that the services are more affordable. And the other thing also the safety factor. Most people don't think about that. But you see, if you go to a place where it's a one-man operation, one-man station, if that person gets it wrong, then you know you have your mess. But in Korle-Bu, you know, the kind of culture that we've created in Korle-Bu, which we are grateful to our predecessors, you know, the Professor Bedus, and you know, Professor Ismo, Professor Bedu, Professor Champong, and Professor Dodu and co. You know, they started the medical school, and there are too numerous to mention. There are some of them who are still alive. Just a few weeks ago, we lost Professor Nkrumah, you know, also one of the foremost pediatric minds. And so this book actually set up a system where it's knowledge that dictates the pace. So it's not the position, you know, or you know, how long you've been, but how much knowledge you have. So the culture is that, let's say, if I see if the medical student will come and clerk a patient, the resident will see, you know, or the house officer will see. The resident will also see. They all make their independent assessment. The specialist will see. The senior specialist will see. The consultant will also see. The professor, you know. So, and we are free to question, you know, things. So that's kind of thing. There's saying that in the model of counselors, there's safety. So if somebody gets it wrong, somebody will ask a critical question, and so you know, and so
it's more like there's a committee. It's not one doctor with.
Exactly.
So they'll check with others.
Check with others, and then where somebody misses something, another person will come in. So let's say if you're working in a team, for instance, then it means that if I'm away, you know, one member of the team will still come and check on you. But if you go to a place where it's just one man station, of course, he's a human being. When he's tired, he goes. So what happens in his absence? And then you also want people who are senior enough to be able to take decisions. Because if something is going on, people need to be able to say, look, this is, you know, has to be done. And then, you know, because let's say if you're doing, let's say some very complex place, like you're doing microsurgery, for instance, and something goes wrong, you need to be able to return the patient to theater within, you know, a certain time frame. Otherwise, you get complications. So it's good to have redundancy. You know, somebody else, because if you are, you know, unavailable, or you know, just because of fatigue, etc., you know, somebody else has to be able to.
One problem I have with Korle-Bu, among many, before I even come to contemporary issues, is there doesn't seem to be the system flow punishes a patient. So you bring, and I'll give a classic example. A friend of mine said he took a baby who was born preterm and had issues. The number of places he had to visit, take blood, go and pay this. He walked almost 6 kilometers. And this is a traumatized parent having to basically be sent on merry-go-round. There doesn't seem to be some logic in, you've come here, go here, go here, go here. So you will walk, you will take, it's like they designed the system to just frustrate you. Why is that like that?
Okay, so one of it is because of the sheer physical size of Korle-Bu. Because the campus is spread over a wide area. So let's say if you need a lab, for instance, the lab is located centrally. And so you may have to move and all that. But we've taken note of that. So what we've done is to try and also improve the way the system works. So you can see that even the pharmacy, for instance, we now have satellite pharmacies in most of the departments. If you take the lab, for instance, we now have satellite labs in the department. And then the new arrangement we are having we've also employed some phlebotomists, so that now the samples will be taken, you know, on the ward. So if you call a number, somebody will come to the ward to come and take the sample. So these are internal processes. In fact, there's one of the, if I was talking about our strategic plan that we are implementing now, it was one of the key weaknesses that we noticed, identified. And so we've been tracking that and monitoring that, you know, and it's, I mean, we've made some significant, you know, improvement, but there's still quite a way to go. So it's all part of the, you know, the customer care orientation, you know, making sure people have that customer care. So recently we employed some graduates to serve us like a concierge, you know, so that when people come, they can help them to navigate the system. Because if you can imagine if somebody's come from a village and comes to Korle-Bu, it's like a whole maze, you know, and people can easily get confused. And sometimes some of these grow boys take advantage of people like that. And so we are trying to improve the internal process. And then we also now encouraging teamwork, so multidisciplinary team approach, so that, let's say, because if you have a condition, for instance, let's say you have an advanced cancer, for instance, let's say breast cancer, for instance, you may be sent to go and see the oncologist. you go and see the breast surgeon, you go and see the plastic surgeon because we need reconstruction, you go and see the pathologist, and all that. So now we are encouraging multidisciplinary teams so that the teams will come together around the patient. So the teams so the nurses will be there, the oncologists will be there, so that they can take one decision. Because sometimes it's a question of synchronizing calendars. It's a question of arranging the treatment so that it makes sense and all that. So once all the players are at the same table, a decision can be taken. Some of the areas that are the thorny issues can be trashed out immediately. So that's the kind of approach we have.
Does Korle-Bu have a system that treats NHIS card holders fairly as against cash and carry?
NHIS, yes, we take NHIS, and NHIS users are encouraged to bring their card along. Okay, and so so we treat it. But then there are some of the things that are not. You see, Korle-Bu is our most complex healthcare service provider in terms of the complexity of what we do. So it's not every condition that we'll be treating there that is covered by NHIS. So that is something that sometimes people misunderstand. Then even when it comes to, let's say, pharmaceutical products, for instance, Korle-Bu's, our drug list is about 1,500, 1,600 medications on it. Now, NHIS drug list, okay, so just about 500 drugs. So you can see that immediately there's a large number of drugs that we will prescribe in Korle-Bu that are not covered by the NHIS currently. So those are some of the. So people don't understand why is it that I can't get this on insurance, but it's because it's not on the package yet. But there have been some strides, improvement in this area because some of the oncology drugs, for instance, through the advocacy of the First Lady, for instance, they have been included. Some of the 4 pediatric childhood cancers have now been included on the NHIS package, and then even some of the drugs for breast cancer, have also now been included. So I mean, we are making sort of incremental strides in terms of
let's do another general issue before I come to specifics. Okay. No bed. You say you are 1,800 to 2,000 bed facility for a hospital that has 8,000 staff. The third largest hospital in Africa. Is 1,800 beds optimal? Or is it that explain to me why can you have more, or the space is not enough? Okay, why don't you have 4,000 beds as an example? I
mean, you could. Depends on you could have more beds. Okay, that's potential because like recently we've put up the Urology Nephrology Center of Excellence, which has 100 beds. So we continue to expand. But I think that this no bed thing is more of a feature of the emergency side of things. Because when you have an emergency and you are rushed to the emergency room, for instance, then you need a bed within the emergency space, okay, so that your condition can be diagnosed very quickly and then treatment started. And then if it's something that requires specialist attention, you'll be sent to the appropriate specialist and so on. But then what's happening is that once you have the situation where a lot of the facilities around do not have a certain level of manpower, so it means that certain things that are referred to Korle-Bu that may not necessarily have required to be referred to Korle-Bu. So Korle-Bu gets overwhelmed because when Korle-Bu was built, you look at the population of Accra. Now the population of Accra is many times what it was when Korle-Bu was built. Okay, but then although we've expanded the emergency room, if we don't address this, then it will never be enough. So, and sometimes people, when we say no bed, people also think of the physical bed. It's not about the bed. See, when people are rushed to the emergency, okay, the emergency means that they have a certain condition that requires a certain level of medical care, or and so the nursing care, medical care, etc. So it's not just a bed in a room with nobody attending to you, but a bed with certain support equipment and also certain facilities to take care of you, because those are patients who are critical and time is of essence. So that is what it is. So it's not a question of just a physical bed. And so sometimes people think, but I went to the surgical block and I found that there were some empty beds on the surgical block. The truth is that the departments are specialized. Okay, and so of course the skills or the dynamics in an emergency room are not the same as maybe in a urology ward or in a
So why can't you say we need more beds at emergency?
It's true. Yes. So yes, you can ask for expansion of the A&E, but if you don't deal with the fundamental problem, it will never be enough.
What's the fundamental problem?
Fundamental problem is that we need a certain level of expertise available in all the institutions that feed Korle-Bu teaching also. So you need, let's say, at least somebody at the specialist level. Now, many of our district hospitals are manned by maybe other physician assistants or maybe just medical officers. We don't have specialists present. So, and then the specialists come in different, I mean, they have their areas of jurisdiction or areas of function. So you need people who have got a certain minimum level of experience or seniority to be able to at least sort out some of those basic ones, so that the ones that are truly complex and require a place like Korle-Bu will be sent on. And then the other thing is also about the communication. So if you look at our 100 ways to celebrate 100 years, one of the things that we are focusing on and want to take is telemedicine. Because sometimes what we realize is that somebody may have a problem that seems to be urgent, but then what they require is not being physically moved to Korle-Bu. But then what they require is a senior person to speak to. So the person, sometimes it's just tweaking the medication or adding some particular medication or adjusting something, and then that person can actually be treated at the peripheral level. But because that expertise is not available and they don't have any direct means of getting that kind of help, then you find that they then send them off to Korle-Bu. Sometimes it's about the finances. Somebody goes somewhere, he doesn't have the means. So of course, most private hospitals will not want to take on that kind of responsibility, and so then it's easy to just refer them to Korle-Bu. But I'm not saying that is like a minor, relatively minor issue. But then most of the time it's about the expertise that is available in the peripheral hospital. And so we need to work on building capacity, and that's why we also undertaking vigorous training to make sure that once you have more senior people working at the peripheral level, the number of referrals will reduce.
Wonderful. This is the point of view. Tonight we're doing a special on Korle-Bu Teaching Hospital, 100 years old, the good, the bad, the ugly. My guest, Dr. Opoku Ariampoma, who's the CEO. When we come back, we'll look at some contemporary issues that have come in the news around Korle-Bu. He'll also share his strategic vision. It was a 5-year vision. It's in his 4th year. So hopefully he's achieved the things he wanted to achieve. All of that and more. Stay with us. Welcome back. Tonight on The Point of View, Dr. Opoku Ariampoma, the CEO of Ghana's largest hospital, the 3rd largest hospital in Africa. I didn't know this. So there's South Africa, Johannesburg, there's Cairo, and there's Korle-Bu. That's massive. He's talking to us about 100 years of Korle-Bu and some key issues. Every day there's a Korle-Bu story. When I check, every week or every 10 days there's a Korle-Bu story in the news. So let's deal with this week's issues. Renal consumables, I think the name is right. Concerns about lack of consumables, some locked up at the ports. You had to deny that people had died because of this. Somehow this kidney thing is a very big issue. Just educate me. Why is the kidney thing so traumatic? And I think in the past year, the kidney issue, whether it's the price of dialysis or renal equipment, keeps coming up. What's going on with that?
Okay, all right. So thank you. So Korle-Bu is the hospital that has the largest cohort of renal patients. And so at the point we had about 300 patients, chronic kidney failure patients who were on utilizing our service. And so in 2017, it was, the management then realized that many people could not afford the cost of dialysis. I actually know several people, when I was a medical student and when I became a medical officer, who lost their lives because of kidney failure because they couldn't afford dialysis. At that time, the cost of dialysis was about $100 a session. Okay, and so that was what it was. And so in 2017, the hospital, tried to look for means of supporting our patients. And so we engaged with this philanthropist, first guy, Mr. Kutoche, who gradually came on board and decided to subsidize the cost of dialysis services in Korle-Bu. So from 2017 to last year, 2023, about 230 patients were on this service free of charge. They didn't pay, so they were getting 2 sessions of dialysis every week free of charge. Now in 2020, when COVID hit, every institution had some challenges. And so of course his business had a challenge because the payments were not as forthcoming as before. And so Korle-Bu, and this was when I was in office, so we had a choice. Either we stop the free service and let the patients pay, or we exercise faith, and prioritize the health of our patients and continue providing the service. So we decided to do the latter, which is to continue providing the service in the hope that, because like the president said, you can know how to revive the economy, but you don't know how to bring back lives. And we knew that if we stop the service, even if the free service resumes later on, many of these patients may not live to see that day.
Okay.
So we decided to prioritize, and that's why we decided to continue providing that service free of charge. So in 2022, we received the payment, the backlog of payments, but then we pay in euros, and you all know what happened to the exchange rate in 2022. So that's how come we developed that 4 million cedis deficit, which thankfully the Ministry of Finance has come in to pay. But that is what started the challenges with the supply chain, in that and the machines we are using are the best machines, but then they use a closed system. And so that closed system, you cannot source the consumables from anywhere else. It has to be from the manufacturer. And so when they were playing hardball with us, it became difficult to sustain the supply of consumables. So we then asked our patients that, we had a sense for our patients, asked them to patronize. Korle-Bu was not the only place providing dialysis services. There are other facilities providing dialysis services around. But the truth is that Korle-Bu's own are the cheapest one, and then it's also the best in terms of quality. I mean, the patients themselves will attest to that, and they've been saying it, on various fora. And so that's what occasioned that issue, because we're, the financing gap. So we're having challenges with the supplies. And so when that was resolved, okay, now the next thing was about the cost, because the price at which we were providing dialysis was about 380 cedis. From 2017, it hadn't changed. And that's the challenge with some of the public institutions, in the sense that our fees are fixed by Parliament. And so even we cannot change our fees to, to reflect the exchange rates and other changes that happen, inflation, etc. We are not able to do that. So we have to go through Parliament. And this Parliament approval is always lagging several years, behind. Okay, so at the time we even did the proposal for the 490. In fact, we proposed 760. That's what we asked for, because we felt that as of last year, that was what would enable us to break even. And the Minister of Finance, Honorable Abna Osasari, was kind enough to allow us to amend our proposal, to reflect that. And so we were expecting approval from Parliament. But when, in the wisdom of Parliament, they approved 491 cedis for us. So that means that for every patient that we dialyze in Korle-Bu, we still are recovering by almost 300 cedis. 300 and something cedis. So that is the challenge.
That's one issue. But why did you close the renal unit 2 weeks ago? No official reason was given.
Yes, so for this current situation, what happened was that we had been engaging with our supplier after we had paid, settled our obligations. We were expecting the next delivery of consumables. So these have been packed, since about March this year. And they were told that they were having challenges with shipping lines, because we told that it's something that's a global phenomenon, where they are not getting enough ships to come through because of what was happened the Suez Canal and other places. I'm sure those of you who are updated to the news and are aware of this. So it affected supply, but then we are sure that it will come imminently. Unfortunately, it's only arrived in the beginning of July. And then we're expecting that the paperwork would be ready, so that we would, for the shipping line, so that we can clear it from the port quickly. But unfortunately, it took a while for the shipping line to get the paperwork released to us. So there's a lot of emails, phone calls back and forth.
So the reason why you closed the renal unit was because you didn't have the supplies.
We didn't have the supplies.
So you couldn't take care of renal patients.
Yeah. So we had to stop doing that, because the outpatient sessions, we do between 60, 70 sessions every day if we are doing outpatients. Okay, but then the emergencies are maybe about under 10. So we thought that instead of allowing ourselves to run off, let us take care of the emergencies and inpatients, and then let's stop that, and let's ask them to patronize the other facilities around in the meantime, so for us to get this going. But then one of the things that is also stirring up this whole thing is that it's not that there are no dialysis, there are no options for dialysis, but it's because Korle-Bu is the only place they can get at that price.
So it's more expensive for them. So when you close the renal unit for one day, people will die.
So definitely, not that they will die.
Or they could.
I mean, it's more like it puts them in
a difficult
situation because then they have to cough up more for their sessions, and so I do understand why.
Fair enough.
People.
So the other issue, the only cancer machine at Korle-Bu cancer treatment broke down recently.
Okay, so that one is also a misrepresentation.
So it wasn't true.
So yes, we have a number of machines there. Okay, so it's like you have a Rolls Royce and you have a Toyota. Okay, you are using both. Okay, the Rolls Royce has its use when you want to go and flex. You use the Rolls Royce. I mean, I'm using it. But then the Toyota is reliable. It always works. So the Toyota has been working, and there's no issue with the Toyota. Okay, so it's not like you don't have a car. So that was what it was. So the Rolls Royce broke down. Okay, that's the one that is more modern and kind of more easier to handle and things like that.
All
so
right.
but then it was fixed within a few days. But then the story came out that the machine, the story created the impression that that's the only machine. And then
so this was the most advanced machine.
This is the most advanced machine.
So obviously to affect.
No, you see what it has that it means that you have a longer queue. But then it doesn't mean that patients are denied treatment. See, and the truth is that tell me which organization has not had a machine breakdown.
So how many
before.
machines do you have for cancer treatment?
The radiotherapy machines are 2.
For the whole of Korle-Bu?
Yes, because these machines are very expensive. They cost, upwards, $55 to $10 million for one. So
you have only 2?
You have 2, yes.
For the whole Korle-Bu?
Yes, but I think...
And I'm sure Komfanoche too has 1. Because recently there was a news in Komfanoche that they also had issue with their own.
Yes. So in fact, we have been actually taking care of most of the patients. When the issue at Komfanoche happened, we've been taking care of...
So between Korle-Bu and Komfanoche, you have 3 of the... Possibly only 4 machines. How many machines like that in Ghana?
I think UGMC
also has 1.
Sorry, Swedish Ghana Medical Center has 1.
Wow.
Yes.
It's $10 million.
Yes, probably even more. But yeah,
but people pay.
Yes. Okay. So for us, because we are government service, so our rates are.
So do you? If we look at all the amounts you get in a day, does Korle-Bu break even? Do you make loss? Is it a profitable entity?
So for a lot of the services, we actually run at a loss. But so we try and get some support, to because at the end of the day, you also look at the fact that if you also want to, so that's a way of like the philosophy of medicine. I mean, in America, medicine is very commercial, so they charge all the rates, and of course, you have to either get insurance or something to pay for it. But here we see medicine as more like a social service, and so that is the kind of model. So most of the institutions are not like for a teacher also in particular. What you'll be happy to just break even, because at the end of the day you are treating people. Although you treat all kinds of people, you also want to make sure that it is not out of reach for the poor and vulnerable. So that is the balancing act that we are doing.
Last 2.5 weeks, 6 health unions petitioned the Ministry of Health not to extend your tenure as CEO. They cited 7 reasons: inefficiencies in absence, shortage of basic consumables, conflict of interest, poor management and leadership style, lack of progress in key areas of healthcare, low staff morale and high turnover, visible fatigue. And they said extending your tenure would be detrimental to the hospital's progress and the well-being of its staff and patients. Health Service Workers Union, Ghana Federation of Allied Health Professionals, Health Accounting Staff Association, Korle-Bu Senior Staff Association, Government and Hospital Pharmacists Association, Ghana Registered Nursing and Midwives Association. That is a serious vote of no confidence.
Okay, Bernard, did you see any name on that petition?
There were signatures and there were positions.
Was there any name?
No, there were positions. So
good.
Chairman, President, yes. Chairman.
Yeah, but why were there no names?
But there were signatures.
Yes, but signatures that anybody can come up with this document.
So are you saying this was forged?
I don't have any way of knowing. But then, if you want to pen such a serious document, then at least you add your name so we know who we are addressing. But at the moment, it's like shadow boxing. You've seen some, positions, because the GRNA president came out to say, look, we don't have anything. In fact, and the Health Service Workers Union, their general secretary was in my office to say, look, I apologize to you, we don't have anything, and this is not the thinking of the union. In fact, and every one of the unions, okay, when my HR contacted them, the executives say this took us by surprise. We've not had any meeting, any discussion whatsoever to come out with anything like that. So it's probably one or two people within the unions who have an, their own agenda or who
but that would be serious forgery then, because
yes.
You have chairman of Health Service Workers Union purportedly signing.
Yes.
Chairman of the other groups
but then the chairman,
signing.
is it your personal view or you take the view? Because if you had a meeting with your members and your members come to a certain consensus, then you would go. But is it, if you've not consulted your members? Because the Health Service Workers Union, for example, we spoke to the secretary of the Health Service Workers Union, and the secretary says that, look, I don't know anything about this. This took me totally by surprise, and so I think I've avoided coming into the public domain because there's a lot of things that have happened, within this 4-year period. And one of the things that I think somebody said that if you fight corruption, corruption will fight you back. And so for me, some of these things do not surprise me at all. And you can see, look at the first reason I was given, checks. Anybody who knows...
In the absence of chief executive, no checks are signed and no activities come to a halt.
Okay, so now we are a hospital. When have you heard that Korle-Bu, we are a healthcare service delivery organization. When have you heard that Korle-Bu patients are not being seen or operations are not being done because the chief executive is absent? So this is very bizarre. And so why checks? So it tells you that, and that's why I tell you that there's, we've introduced some serious accountability systems and of course, nobody is going to be happy with accountability. In fact, that is one of the things. But I've refrained from, because I can give a lot of examples.
You don't want to, but I need to just mention something. I said delays in approvals have resulted in frequent shortage of essential supplies.
You see, and that's also not the case, because we are engaged with the procurement people, and we've had from 2020 coming, we've had some challenges with consumables. So I'm not going to say that nothing like that has happened. But then what is the reason? The reason is not because the chief executive has not approved anything. But what's been happening is that we have framework contracts. So somebody is supposed to supply us consumables for, let's say, a year. We have a contract, okay? Mm-hmm. Then a person comes by and says, look, because the exchange rate has changed, I want to adjust my prices. And then, so there has to be some negotiation. Of course, sometimes they try and, kind of play hardball, and also. So this is something that we've tried to manage as much as possible. So it's not because the chief executive.
So are you saying that the administrative measures you've put in place to ensure the right thing is done is what is creating this?
Yes, because some of that, because this is not the first time. This kind of things have started a while ago, and so it doesn't surprise me. Of course, sometimes, unfortunately, some people may not have the background that I have. Okay, but let me give you an example. And in fact, some of the approvals, for instance, we were buying 144,000 spinal needle sets. The things that we use for spinal anesthesia. We were buying 144,000 every year and exhausting it. Okay. Now, when I did the data, we've also done some work on our data quality, because if, as a chief executive, you are taking decisions,
you need data.
You need good data. Now, when I validated the data that we were getting in 2021 mid-year with the PPME unit, which have done a fantastic job, our data validity rate as a teacher was 18%, 1.8. So if this is the kind of data you have, then of course you are at sea, because it has no bearing on the reality on the ground. And so through a series of measures, and continuous education, training, etc., our data, because when we did the mid-year review this year, we are now about 73%. Okay, and this is within a space of two years. Okay, so now, so when you have accurate data, you are now able to track things. And so we're buying 144,000 spinal needles a year. Now, we look at data, we realize that we're doing less than 10,000 spinal cases in a year. So even if you take it that look, for every one case you do waste 2, you don't need more than 30,000. Okay.
So you cut down the number they bought?
Exactly, yes. So we cut down the number to 36,000. We've not run short. So you can ask, the question remains, where was the rest going? If you take even our kitchen, for instance, the food quality was very bad. Most people who come on admission don't want to eat the food. So relatives have to now, bring food to them, by force, to the. Meanwhile, we're billing them for food. And and it was terrible. If you look at it as you feel very bad that this is the food we are serving to our patients. Now we did some changes, focus on it, did some changes there, and the food quality. So if you look at 2022, verse 2023, for instance, where we made those beginning of 2022, we made those changes. month on month, although there was inflation in food prices, we were making savings of over 250,000 every month on food purchase. So last year alone, we made savings of over 2.5 million cedis on just food purchases. Meanwhile, the quality of the food has gone up significantly. Okay, and now patients are even getting fruits sometimes and other things, and getting, better meals, far better meals than we've known. So these are some of the things. And so, of course, not everybody's going to be happy. I can go on and on.
Let's take a break. This is the point of view. Tonight we're trying to understand Korle-Bu. They are 100 years old. When we come back, we'll talk about what they are doing to celebrate 100 and what the CEO would say has been his greatest change he's brought to the institution 4 years down the line. Stay with us. We're still talking Korle-Bu Teaching Hospital, Dr. Opoku Arampoma, our guest. Korle-Bu is 101 years old. They're celebrating 100 years. They have a very interesting thing. They have 100 ways to celebrate 100 years. And I thought it was quite interesting. So I'll just read a few for you. So some involve them, some involve you. Adopt a ward or a project campaign. Launch Korle-Bu at 100 paraphernalia. Develop a digital map. Review current care pathways, training on appropriate laws and policies regulating the teaching hospital, launch of Korle-Bu staff Medicare scheme, institutionalize Medicare, revamp Korle-Bu trust fund, select sub-specialty training in critical areas to position the hospital as a medical tourism hub, hospital-wide lighting project, improving the signage of the hospital, crowdfunding to support needy patients with critical health conditions. This is quite interesting. So you picked 100 things you would do. How many of them have you been able to do?
In fact, we've done quite a number of them, and then a number of them are also in progress as you speak. A few of them that we are yet to
100 things to do.
Yes.
And where was this from? Was this from like people just bringing ideas also? How did
so what we did was that we tried to, I sent out memos to the generals of the staff that we are Centenary, they should bring, we are tapping ideas as to what, the things they think we can do to celebrate our centenary. And then we also haven't been, haven't been apprised of the challenges within the institution. I felt that this was actually a better way. There's no better, testament or no better way of celebrating the 100 than to also undertake projects that will actually address the real problems on the ground. And so that is what informed, these 100 ways. And we are grateful that we are getting some support from, corporate entities, individuals,
So when are you climaxing the celebrations?
Okay, so the climax will be towards the end of this year. So at the end of September, we are doing a dinner, 27th September, we are doing a dinner dance and also a fundraising where we are also going to launch our legacy project. Because we have a legacy project. We have other projects that we are taking, but we also have a project we've called the legacy project where we want to develop a skills, skills research and learning center, for the hospital.
So all of that end of the year.
Yes.
What is, when you took over 4 years ago, you said a lot of things. What do you think the top 2 or 3 most important things you've done as CEO?
Okay, so one of them, most people like to talk about monuments, okay, or infrastructure, hard things that you can see. Now, I have a lot to can talk about. The Urology Nephrology Center of Excellence, thanks to the government of Ghana, the new FIVES units, the Infectious Disease Center, which has been done, the Rebecca Kufuor Sunshine Hostel, all these were commissioned in my time. The Diabetic Center has been rehabilitated. The number of wards have been rehabilitated within my time, and we continue to do more. So surgical 6th floor, surgical 1st floor, surgical 2nd floor, Ward E, the polyclinic wards, the dental place, for instance, we brought in new dental chairs, we brought in new equipment for radiology, 15 ultrasound machines and other equipment, the cath lab, $3 million facility through the instrumentality of essentially the vice president, we got that done, which has helped us do interventional radiology. We brought a new fluoroscopy machine to do other procedures, which we couldn't do before. We had to send our patients outside. We've got a new CT scan. In fact, last week, for instance, there was a story about the CT, our CT and MRIs were not functioning, which is not true. Our CT and MRI are functioning. And in fact, the person who was on air to give that story was actually one of the people who has been trained on this brand new CT scan, 128 slide CT scan, state of the art, which is installed in the Urology Nephrology Center of Excellence. So what was the motive? Why would somebody who has been trained on the machine, has had trained on the machine, go on air to go and say that we don't have functioning CT scan in Korle-Bu? So you can see some of that. I don't want to go, but then in terms of infrastructure, there's a lot that has happened. The new patient lounge, which was funded by Atlantic Bank and various other infrastructure projects.
So you're basically saying there are different developments going on.
Yes, different developments going on as we speak. More renovations.
What about the customer service of the
that's
hospital?
what I'm coming to. So, but then for me, my focus was not just on hardware, infrastructure, logistics, etc. We thought that the software, because a lot of times it's easy to for people to focus on some of these things because it's easy to point at it, say, evidence of what you've done. But see, I believe that organizational culture is one of the most critical things. And there's a Harvard, Don, who said that the best way to predict the future of an institution is not the financial books, but the organizational culture. And we felt that we needed to introduce certain changes in the organizational culture, the culture of accountability, culture of customer care, a culture of putting the patient first, because we needed to, although we have it on our motto or other things, but we need to practicalize it and make people feel the difference. And so we've done digitization of our operation now. We're using a paperless system. We had these challenges, but we are, improving it as we go along. But then we also needed to look at the software issues. So do we have the right, staff? Do they have the right mindset, the right attitude? Do you have the right skills, and do you have them in the right numbers? So those are the kind of things. So we came out with a 5-year, HR training plan. So every department, every unit had to come up with a 5-year plan. So that our hope is that once that 5-year period is over, we would have trained people in each of the different subspecialties areas, so that every patient who comes to Korle-Bu, would have somebody within that certain subspecialty that can deal with their problem. So that is ongoing. We put up the plan in 2021, finished in 2022, and so we started rolling that. It's a 5-year plan. So that the rollout is still ongoing, so that we can target specific areas. That's why we've sent somebody to Korea to go and do a kidney transplantation. There are people who are in India, other places, or learning advanced skills. There's one of our fellows who is in South Africa now, Durban, South Africa, doing craniofacial surgery.
Will they come back?
Yes, we trust that they'll come back. The thing is that
because a lot of doctors, when they go, they don't come back.
Okay, so it's those who go on their own.
This one you send them.
We send them, but then the truth is that we also are careful who we select. I mean, Touch would have sent so many from the plastic surgery units abroad, and all of them have come, and nobody has failed to come. So you select the kind of people. You look at people who have a passion for it, people who want to make a difference, And the truth, what you also do is that you also don't take them away for too long. When people go 2-3 years, they'll come back. When they start going beyond 4-5 years, then they start laying roots there, and so that it becomes difficult for them to come back. But we are looking at it. But so far, so good. We have some of our female people going to do interventional radiology in Canada.
So you're talking about infrastructure, customer service,
yes.
Sometimes when you go to Korle-Bu, the lifts don't work.
Yes,
the washrooms are a mess.
Yes,
these are basic things.
Yes, so what we are also doing is that's what talking about the accountability systems, because every department has a head, and that head has to be responsible. There's a team, there's a management team at every department. So it's the CEO has got overall responsibility, but then CEO cannot be everywhere. And so that's why we are using this centralization approach, empowering the department so that they take ownership, so that they have their own work plans. So if, let's say, a department says they want to buy a piece of equipment, one of the things I ask is that, okay, so what's the maintenance plan? What's the plan for it? How do you plan to pay back for this equipment and so on? So they do their own budgets, they come up with their own, and then they come and defend it. And then everybody asks questions. So once you have this academic systems, everybody can ask them questions. And then we have, whatever you present, we have peer reviewers, people that we've trained. So far we've trained about 700 people from various backgrounds, so that they can now come and validate whatever it is that you put across. So that is improving the accountability. So now, because previously we didn't used to have those kind of exercises, so that every quarter you present your reports, half year you do.
So do you have the power to fire a departmental head if the lifts there are not working or the toilets are not functioning?
Unfortunately, in the public sector, it takes a lot to even
so
fire.
So how do you sanction errant or ineffective heads?
So you can query them, you can talk to them, you can you try various means to, because in fact that's one of the challenges. I can tell you on this platform that we had a situation where some accounts staff, okay, were pilfering money from the price surgery units, where when I was I was head, and to the tune of about $50,000 a year. And this is something that we managed to find out, and then so Yoko had to come in to arrest them. And this arrest was done in 2015. Okay, prosecution started in 2016. The case has not been finished as we speak. So that's some of the challenges that you have, because unfortunately the judicial system is not as
from 2016.
So from 2016. So that is what creates that impunity. So and in fact during COVID. There was a case of some staff who were, doing things with the vaccines that, were authorized and all that. And when we tried to query them, go to them, they've gone to court, place an injunction on disciplinary process.
Wow.
And so
you have to go with that.
Exactly,
this is the rule of law.
So sometimes if you want to, it makes it very difficult. So what you do is that try and find a way of solving the problem, and just navigate. Otherwise, you will get yourself encumbered in all these things, and then and just become distractions.
It's a tough job.
I'm saying that one of the things that I'm proud of that we've introduced is the 100% staff Medicare scheme. Okay. Because previously our staff did not. Like when they are sick themselves, they have to take care of their own bills, which was not fair. And so my predecessor started the 50% refund scheme, but then we thought that no, we need to take care of them fully. So we said 100% staff Medicare scheme, so that if you're a staff of Korle-Bu, you fall sick, you are taken care of. And, take off.
We'll have to leave it there. Yes. That's what we have time for. Thank you very much, Dr. Opoku Ariampoma. Thanks for watching tonight's edition of The Point of View. We'll be with you next time. Bye-bye.